Hello everyone, I'm Jeon from Korea University Annam Hospital. Today I'm very honored to introduce our new research topic at this academic conference. Our new topic is clinical outcome in adult-to-adult living donor liver transplantation using left liver graft, with versus without caudate lobe. In adult-to-adult LDLT is a dominant type of liver transplantation, especially in Asian countries where deceased donors are extremely scarce. In Korea, as you can see in the figure below, the number of patients on the liver transplantation waiting list has been steadily increasing, whereas the number of deceased donors and living donors have shown a declining trend. As it further aggravates the imbalance between the demand and supply of liver graft, tremendous efforts are required to promote not only deceased donor transplantation, but also living donor liver transplantation. Generally, there are two main types of liver graft, left and right lobe. Historically, left lobe grafts were first introduced in 1989 in adult-to-child LDLT. Soon thereafter, left lobe hepatectomy was extended to adult-to-adult LDLT. However, concerns regarding insufficient graft volume for recipients led to development and widespread adoption of right lobe grafts, particularly with development of extended right liver grafts. More recently, heightened awareness of donor safety and long-term risk have renewed interest in the use of left lobe grafts. So at present, the choice between right lobe and left lobe graft is largely based on donor and recipient characteristics, requiring balance between minimizing donor morbidity and ensuring recipient survival. Still, right lobe grafts are more commonly used in LDLT due to higher GRWR. Higher GRWR supports graft recovery in recipients with high metabolic demands. However, left lobe graft remain an important alternative when right lobe donation is limited by small future liver remnant. Truly, left lobe graft have certain limitations, including increased risk of small foresight syndrome and several technical issues such as multiple hepatic arteries and difficult venous outflow. However, nowadays we have a lot of evidence about improved outcomes with portal hemodynamic modulation. Also, as all you know, in terms of donor safety, there are fewer complications in left donor hepatectomy compared to right hepatectomy. Also, most donor deaths occurred after right hepatectomy. This was a study published in 2018 showing comparable outcomes of adult LDLT using left lobe graft compared to right lobe grafts. Therefore, if the left lobe graft can provide the minimum GRWR required to ensure recipient recovery, actively performing LDLT using left lobe graft can ultimately enhance donor safety and contribute to the wider adoption of living donor transplantation. Furthermore, there are more unusual graft types such as right posterior graft or left liver graft with caudate lobe. So in this slide, we would like to compare the left liver graft with or without caudate lobe. Left liver graft means left liver with middle hepatic vein. When compared to the left liver graft with caudate lobe, it provides less burden for donor because it's safer. In comparison, left liver graft with caudate lobe is slightly larger. However, it also has limitations because it requires complicated reconstruction of inflow and outflow of caudate lobe. Now, I would like to further explain the advantages and disadvantages using the left liver graft with caudate lobe. Firstly, including caudate lobe provides small but significant S1 volume. We, in our center, analyzed 10 patients who underwent a pure laparoscopic living donor liver transplantation with caudate lobectomy. The estimated caudate lobe volume was 35 grams, and its corresponding GRWR was 0.05. So especially for patients at high risk of small foresight syndrome after liver transplantation, it can be really significant for recipient survival. Secondly, as caudate lobe is anatomically located posterior to the inferior vena cava, it's not proven, but our center believes and suppose that it can provide physiologic configuration of the portal vein to help maintain stable graft function. It's more evident when you see it on image. The figure here compares the angle difference of portal venous flow in the left lobe graft with or without caudate lobe. With caudate lobe located behind IVC, it provides less steep angle for portal vein in sagittal view on CT. With less steep portal vein angle, it can minimize hemodynamic disturbance and help liver regeneration immediately after liver transplantation. However, caudate lobe inclusion also has some limitations. In donor perspective, inclusion of caudate lobe in left hepatectomy is technically more demanding. To including caudate lobe, portal inflow and venous outflow must be secured, so the complete mobilization from the IVC is required. However, with the recent shift toward minimally invasive donor surgery and advances in surgical techniques, increasingly complex laparoscopic procedures are being performed, so we believe that the learning curve for caudate resection has been largely overcome in most centers. Moreover, when the caudate lobe is attached to the left lobe, in our clinical experience, the handling maneuver during the parenchymal transection can be facilitated. After caudate dissection, the shortened hilar plate can also provide technical advantages during the bile duct division and hilar plate management. In recipient perspective, including caudate lobe means that it requires anastomosis of caudate vein to IVC. In our hospital, we routinely perform anastomosis of V1 to IVC after middle and left hepatic vein reconstruction. The figure on the left shows the bench surgery. We are performing the venous fence using the grease saphenous vein for V1. It's performed when required for easygoing anastomosis and efficient outflow after the anastomosis. There are a few, but not a lot, previous studies regarding the inclusion of caudate lobe to the left liver graft. In 2001, a Japanese group reported 6 cases of living donor liver transplantation using left lobe graft with inclusion of the caudate lobe. They found that caudate lobe increased in volume by an average of 152% 1 month after transplantation, suggesting that the caudate lobe may play an important role in graft recovery when using a left lobe graft with a marginal GRWR. Also, another study in Japan showed that the Kyushu group has been actively performing living donor transplantation using left lobe graft with caudate lobe inclusion, and reported that since 1999, most cases except for 16 employed left lobe grafts with caudate inclusion. However, as you can see, most published studies to date have been limited to single institution case series or technical notes, and systematic cohort studies directly comparing the standard left lobe graft with left lobe graft, including the caudate lobe, are still scarce. Therefore, the aim of this study is to compare the clinical outcome in LDLT using left lobe graft with or without caudate lobe. In this way, we would like to determine whether caudate inclusion provides meaningful benefits or introduces any additional risk for both donor and recipients. We retrospectively analyzed 65 patients who underwent living donor liver transplantation with left lobe graft at Korea University Annam Hospital and Ansan Hospital between 2010 and 2024. The outcomes, we compared the outcome in both perspective of donor and recipients. For donor, we compared the surgical outcomes and graft-related parameters. For the recipient, we compared the perioperative outcomes, post-operative complication, and survival. In this study, specifically, we would like to compare the portal vein velocity change and the hemodynamics before and after the surgery. Actually, our institution is one of the most active centers in Korea for LDLT using left lobe graft. When both left and right lobes are possible, we prefer left lobe hepatectomy because of the donor safety. In addition, through basic and clinical research, we have extensive experience in investigating small foresight syndrome by portal hemodynamic modulation. Therefore, through this research, we hope that we can promote LDLT with left graft and expand transplant opportunities for patients who were not able to perform LDLT because of the small future liver remnant. Thank you for listening to my presentation.